Hey guys, welcome back. Today we're going to be going into Chapter 7, Airway Management. Looking at the National EMS Education Standards for this chapter, there are quite a few. We'll go through them really quickly. Airway management, respiration, and artificial ventilation. We are looking to apply knowledge of general anatomy and physiology to assure a patent airway, adequate mechanical ventilation and respiration while awaiting additional EMS response for patients of all ages. We're going to look at airway management within the scope of practice of an EMR, looking at airway anatomy, airway assessment, and techniques to ensure a patent airway. Respirations, looking at the anatomy of the respiratory system, physiology and pathophysiology of respiration, including pulmonary ventilation, oxygenation, and respiration, assessment and management of adequate and inadequate ventilation, and artificial ventilation. When we talk about artificial ventilation, we will talk about minute ventilation, alveolar ventilation, and the effects of artificial ventilation on cardiac output. We'll talk a little bit of pathophysiology, using simple knowledge of shock and respiratory compromise to respond to life threats. Recognize and manage life threats based on assessment findings of a patient with a medical emergency while awaiting additional emergency response. We'll look at the anatomy of the upper and lower airway. So this chapter goes over two of the most important life-saving skills that we can do in emergency medicine. That's airway care and rescue breathing. Patients must have an open airway and maintain adequate breathing in order to survive. By using some simple skills, we can often make a huge difference between life and death in these patients. And that really starts with our ABCs, looking at the airway, breathing, and circulation. To maintain all human life, humans need to take in food, water, and oxygen. Lack of oxygen for even a few minutes can result in irreversible damage and even brain death. If the brain is deprived of oxygen and nutrients for about 4 to 6 minutes, the cells in the brain begin. Brain death is then followed by death of the body. The main purpose of the respiratory system is to provide that oxygen to the rest of the body and remove carbon dioxide from the red blood. Here we have a diagram of the anatomy of the respiratory system. You can see that it's broken up into upper airway and lower. The parts that we use essentially for breathing include the mouth and nose, into the throat, down into the trachea or the windpipe, into the lungs. We also use the diaphragm, which is the dome-shaped muscle between the chest and abdomen, and then all of our accessory muscles throughout the. In an unconscious patient that is lying on his or her back, the passage of air through the nose and mouth can become blocked by the tongue. The tongue is attached to the lower, and as we relax, or if we're unconscious, then that lower jaw can relax down, allowing the tongue to partially block the airway and produces a snoring. Here you can see a cross-cut diagram, just how that tongue can move down and start to block the airway, causing that snoring. Continuing down, looking at different parts of the respiratory. At the back of the throat, it splits off into two different passages. We have the esophagus, which is the tube that our food goes through down to our stomach, and then the trachea. As we move in, we have the epiglottis, which is a flapped valve that allows air to enter the trachea, but prevents the food and other things from entering. Then once we move down the trachea, our airway divides into two different bronchi and into each lung. The lungs are located on either side of your chest, separated by the. As you move further into the lungs, those large bronchi that have branched off from the trachea continue to branch down into even smaller bronchioles. And at the end of each of the bronchioles, there are tiny air-filled sacs called the exchange of oxygen and carbon occur at the alveoli, and this is known as alveolar. We also have what's called minute ventilation, and this is the amount of air that is just pulled into the lungs and then removed from the lungs within. Here you can see a diagram going down and looking at those structures of the alveoli, those little air-filled sacs. You can see that there are a lot of capillaries surrounding these. That is required for that transfer of oxygen and carbon dioxide so that we can circulate that oxygen. The lungs themselves are a soft, spongy tissue. There are no muscles involved, but there are muscles in our chest that allow for that ventilation. So movement of air into the lungs depends on movement of our ribs and our diaphragm. So our diaphragm is that large dome-shaped muscle separating our chest from, and when it contracts during inhalation, it flattens out and moves down. And then on exhalation, as it relaxes, it moves back up and becomes dome. Here you can see a diagram just looking at how the chest expands on as that diaphragm flattens out. The chest opens up more, air is able to flow in through negative pressure. And then as the diaphragm relaxes and moves back up, the chest then contracts back in and air. All of our assessments, all of our treatments go in this pattern of ABC, airway, breathing, and circulation. So starting out, that A is for airway. In a healthy individual, the airway automatically will stay open and we don't have to worry about it. But if you become injured or seriously ill and you're not able to protect that airway anymore, it can become blocked. And we talked about how the tongue is one of the first things that will block our airways as we relax from either that injury or illness. So it's important for us to initially take the steps to check that airway, to make sure that it's open and to correct any problem. So as we approach our patients, we're initially going to be checking for responsiveness. So walk up to them, hey, are you okay? If you get a response and they're talking to you, then we can assume that they're. If there's no response when you're walking up to them, then gently shake them, touch their shoulder, try and repeat your questioning. Hey. As you do that, they may be aroused, they may wake up a little bit and start looking around. That doesn't mean that they're able to protect. If they don't wake up, if they don't respond at all, then that patient, if you're coming up on them and you're the first one on scene, then call 911 before you do anything else, get help coming. Realistically though, at this point as emergency medical responders, we are probably responding to somebody who has already had 911 called because they were. Once you have called 911, if you're the first one coming up on these patients, then you can position the patient in a way supporting their head and neck and placing the patient. Quickly scan the patient. As we do this, we're going to look, listen, and we're going to check for signs of breathing by looking for chest rise and fall. And also we're going to start feeling if the patient has a pulse, but they're not breathing, then we need to correct that by opening their airway and possibly. So if we've come up to these patients and we've found that they're unresponsive, we're not sure if they're breathing, we need to first correct that blocked airway. So we've gotten them on their back, and the first thing we're going to do once we have them placed on their back, then we're going to place our hand on the patient's forehead and our other fingers on their jawline. And this is called the head tilt chin lift, where we just apply a little bit of pressure backwards and lift up on the bony part of their jaw, this will be the first way that we'll be able to open up their airway to see if they start. If for whatever reason we're unsure if there was a spinal injury or we're just not able to move their head back, the other way that we can open up the airway is, so what we're going to do with this one is we place our fingers behind the lower part of the jaw, and then we're going to lift up. And as we lift up, it's going to move the tongue out of the way. You can also use your thumbs a little bit of back pressure as you're pushing on their cheekbones to help you as you pull up. All of these things that we're doing in order to open and correct their airway is to try and get them into what we call the sniffing position. And what that's doing is we're trying to get the ears to the sternal notch. And so think about if somebody were to hold a bunch of flowers in front of your nose and you were to like lean forward to smell them, it's moving the airway more forward into a neutral position, trying to get that tongue out of the way so that their air. Some potential things that we could have that would block our airway could be secretions such as vomit or mucus or blood. You could also have foreign objects in there. It's really common, especially for kids, to choke on candy. We could choke on food. If you found this patient unresponsive, upside down, then they could have dirt or mud or other types of debris in there as well. And then some of our older population and some of our younger population, they could have dentures or false teeth that are causing a blockage to their airway. So as we're doing these maneuvers, as we're doing the head tilt chin lift or the jaw thrust, we need to also be looking in their airway and just seeing if there's anything that is blocking that airway. If you see something and you can actually look in and see it, then go ahead. If the mouth is clear, then we're going to start considering using. If you do look into their mouth and you see something, these really need to be only if there's something you can see. There is special equipment that we have once you call and you have an ALS ambulance that has been dispatched to your location, and they'll be able to get things out of the airway that are deeper. But we can also use suction is another thing that we can help to get rid of some of the secretions or blood or more liquid. Here you can see a handheld manual suction device. These are relatively inexpensive. They're compact. They're really easy to use for emergency medical responders. All you do is you insert the end of the suction tip, and then it's a bulb suction like maybe you've used with little kids before, and you just continually squeeze that bulb suction and it will create the suction that we need to get rid of. Along with the handheld bulb suctions, we can also use, so if you have a mechanical suction device, you can turn that on, insert it into their mouth, and then suction out. It does say not to suction for more than 15 seconds at a time for adults, or 10 seconds for an infant, and 10 seconds for a child, and 5 seconds for an infant. That would be on your test, and it's a good thing to know. In practice, though, you may end up with patients that just have continuous secretions, and it's far better to suction that stuff out of their mouth and make sure it's not getting into their airway than to limit the amount of time that you're suctioning. The only real thing, and one of the reasons why they talk about it, is if you go too deep with your suction, then you can stimulate the vagus nerve along the back of the throat, and that can have other problems. So just make sure you're not sticking the suction too far down into their mouth, but clear out. It's more important to clear out the fluid than to make sure you're only in there. Here you can see a picture of one of the common battery-powered suction devices that you may have. For our unconscious patients, once we have placed them into a position and we're opening their airway, if we are doing either the head tilt chin lift or the jaw thrust, it's important that we maintain that position. If the patient is breathing adequately, then we can place them into. If the patient is unconscious and breathing and into this air, you place them into this recovery position. It will help maintain an open airway for them. It allows secretions to actually drain out of the mouth using gravity so that we don't have to continually suction. And it also uses gravity to keep the patient's tongue and lower jaw out of the way. So here you can see a patient that has been placed into the recovery position. You're going to roll them onto one side head. You use one leg kind of as a kickstand to make sure they don't roll too far forward. And then using their arms to kind of support their head, allowing the secretions to drain from their mouth, but making sure that their airway and their head doesn't turn all the way down and become blocked again. Another way that we can open their airway and make sure that it stays open and maintained is by using some of our airway adjuncts. And we have oral airways, and both of them function similarly, but are slightly different. So we're going to start by talking about our oral airways. The two main purposes of our oral pharyngeal airways is to maintain the patient's airway, but also it's able to function as a pathway for suctioning for us. So these ones are used on our unconscious patients who are breathing and possibly are in respiratory arrest. The important thing with our oral airways is they cannot. Oral airways can be used with other mechanical breathing devices, such as our BVM. It's important that we select the correct size. So when we're measuring our oral airways for our patients, we're going to be measuring from the corner of the mouth down to the earlobe. And so if we take this orange one here and we stick it at the corner of the mouth and we go down, we can see that it's way past the earlobe. So that one's going to be too big for our patient. We can move down a couple of sizes and look. And so that one at the corner of the mouth goes right to the earlobe. So we know that this is going to be the for our patient. So when we insert these, we insert them a little bit different for adults versus kids. And the idea is that we want this curve to, and so we're going to stick with the adults. You stick the curve towards the top of the mouth and then twist it 360 as it goes down and insert it, and that is going to help out of the way. Alternatively, what you can do is you can mouth. You may find it's a little more difficult and their mouth needs to be more open for that to be able to go in from the corner of the mouth. So you could go in and twist 90 degrees and that will also hold the tongue up out of the way. The difference with our kids is because their soft palate or the top of the mouth isn't as formed as we have it in adults, we don't want to stick this in with the curve going up and then turn it the 180. So with our kids, we will either go in from the side of the mouth or we will use a tongue depressor or some other thing, whatever we have. I often will just grab in and grab their tongue and their lower jaw and hold it out of the way. And then you insert the airway straight down and then you can release it and it will hold their tongue up out of the way. And once again, if you have a good placement, you'll see that it will sit right at their lips. There are different airways, the ones I'm using versus the ones that you see in the diagram, but they both should sit at their lips. If you start to insert this, like I said, they cannot have a gag reflex. So if you start to insert it and they start to gag, then we cannot use it and we'll have to move on. The different type of airway that we're going to use for our patients who are unconscious with a gag reflex, or even patients who are conscious but unable to properly maintain their airway, is going to be our nasal pharyngeal airways. These ones, because they're not stimulating that gag reflex, the downside is you're unable to. Same thing, we need to make sure they're sized properly for our patients. And so with these ones, we're going to measure in a similar way that we did with our orals. The orals we measured from the mouth to the tip of the earlobe. And so with our nasal airways, we're going to measure from the nose to the earlobe. Now, the ones that I have right here are a little bit different in that they are adjustable. They have a ring on them that allows me to adjust the size to make sure that they're not going too far in. The ones in the picture in your book do not have this adjustable ring on them. And so you will actually measure and find the right one size. When you're inserting a nasal airway, you want to coat it with a water-soluble lubricant. It's really important that we don't ever use petroleum products in the airway. And this is because of the reactions that can happen between petroleum products and oxygen once we start using our supplemental O2. So make sure we have a lubricant, lube it up. For my mannequin, we will use actual mannequin lube. And then once you have your lube on there, you're going to want at your patient. Every person is going to have a larger nostril. Normally, it is going to be the right side, but not always. When we insert these, there is a nap to the nasopharyngeal airway. And so we want to follow that if we can, but we also want the bevel, which is this cut part, to be septum or the middle of the nose. And that's just to make sure that it's not getting caught on structures that are inside the nose. When we insert it, it's going to be inserted straight down, following the roof of the mouth. We don't want to insert it back towards the top of the nose, as that is just going to cause it to curve. The airway goes straight back. So we're going to look at our patient. We're going to look at which nostril is bigger. On my mannequin, it happens to be the right. We can open their nose up a little bit. I like to call this pigging the nose. You just pull the tip of the nose back. It helps open that airway up. And then you insert. And if you've measured it properly, then it should stop right at the nair. If you wanted to and you were able to, you'd be able to look inside their airway and actually see the tip of that right in the back of their mouth. But once you have that in place, it's going to allow for their airway to be maintained. Once we have made sure that our patients have an open airway, then we move on to the next part of that assessment. So we've already done airway. Next is breathing. So our B is for breathing. Now we're going to look, listen, and feel to see if we can notice any chest rise or fall. We're going to feel to see if we feel any air passing. Normally for adults, they will have a resting respiratory rate or breath rate anywhere. If we do notice less than that, or if we notice noisy respirations, whether it be that snoring sound, gurgling, wheezing, sometimes our patients will have gasping respirations. We're also looking at this point at their skin just slightly to see if it's pale or blue, which would indicate that they don't have movement throughout the body. But the most important things that we're looking for in this first stage of breathing is looking for a lack of chest movement, a lack of breath sounds, or feeling. If our patients are not breathing, then we call this respiratory arrest. Some of the most common causes of our respiratory arrest are going to include heart attacks, any mechanical blockage of the airway, including obstruction from our tongue or the candy. It can also be caused by illness. We can also see respiratory arrest in some of our drug overdoses, poisonings, if they have severe loss of blood, or if there has been. As we to the assessment initially to see if there's any chest wall. If they're unresponsive or unconscious, do a quick scan to see if they're breathing. If they are unresponsive, you need to determine if the patient requires assistance. If you notice that they're not breathing, then we're going to need to move into correcting. The first thing that you can do would be mouth to mouth. This is not necessarily recommended in the healthcare setting. OSHA actually looks at this. So if you're going to be doing rescue breathing on your patients, it's recommended to have a barrier device, but it is important to know how to perform mouth to mouth. So the first thing you're going to do is you're going to pinch the nose as you have that open airway. Take a deep breath, place your mouth over the patient's mouth and breathe in, looking for chest rise as you give that breath. After the first 2 breaths that you've given the patient, then you can continue to breathe for them every 6 seconds. The preferred method of doing rescue breaths for our patients, instead of mouth to mouth, is going to be a mouth to mask rescue breathing. This enables us to perform rescue breathing to mouth contact with the possible, and also if the patient begins to vomit, then it protects you a little. So our mouth to barrier rescue breathing, most of these devices are small enough that they can be, or in our bags. Just make sure that you have some type of device. The masks that we use are also the same masks that you would have in your mask. That's stupid. So if you have one, a mask, but you don't have a bag available to you, then just know when other EMS personnel arrive, they can use this. So we'll go over just some of the skill involved in using a mouth to barrier device. So you want to make sure that you have a properly sized mask. They come in adult, child, infant. So your adult size is going to fit patients. Make sure you have a good seal. You can see that it's shaped differently. So it does have a portion shaped for the nose and then a part for the jaw. Place it over the patient's nose and then over their jaw. I like to spread it out a little bit as I'm putting it on, just to make sure that we're getting a good seal over the corners of the mouth as well. Then we need to hold this down. There are 2 different methods that we teach for how to hold this in place. We have what's called the CE method, where you're making a C with your thumb and forefinger and an E with the rest of your fingers. You can do the C's on the mask holding it down, and then the E holds the mask into the patient's face, making sure that you're on the jawbone and not pushing on the side underneath their neck. That one is a little more difficult to maintain, and while it has been taught for years, we are moving more to a 2-thumb method, where you just use 2 thumbs to push down and hold the mask in place. and then you actually use the rest of your fingers to pull the jaw up. And we talked about that jaw thrust maneuver. And so that's what we're doing with these patients, is we're doing a jaw thrust and pulling the jaw up into the mask rather than the mask down into the patient's face. So then we're able to maintain that open airway, and then we just need a little bit of movement in my lungs there. But that's all we're looking for, is create that seal. When you're giving your rescue breaths, you want to try and maintain that normal breath rate that our patients would have. So you're looking to breathe every 6 seconds, which would be once. If we are responding on our own and we don't have more equipment with us, like an aid bag or something that has a bag mask device in there, then we would be doing these maneuvers where it's just mouth to mask. The preferred way for us as responders is going to be to use breathing. With these, our mask gives the air as we squeeze it through a one-way valve into the mask and into the patient's mouth. As the patient exhales, there is a second one-way valve that allows the air to escape. It is important to know that with these bags, where from 1,800 milliliters to about 2,000 milliliters, and the normal breath size for an adult is between 400 and 600 milliliters. So these bags have a lot more than we need to give to our patients. So when we're breathing, we're not squeezing the entire bag and emptying everything. We can just squeeze even with 2 fingers and just give a little bit of breath, looking for chest rise, making sure that we're not overinflating the lungs. Another safety device in these bags is they actually have a pop-off. So if you do start to create too much pressure, this pop-off valve will activate so that we don't cause. So the steps that we're going to follow for using the bag valve mask is the same. We're going to make sure that we have a good of the mask on our patient. The issue becomes if you are a single provider, it will become more difficult to get a good seal on the mask. At that point, you are going to have to do that CE method, creating the C and pushing down, using your other fingers to try and lift the jaw up. And then you're going to notice that you get some leak as you're bagging on the side that you don't have a hand down with the seal. So what I do at that point is I actually pull the mask or the bag down, which will create pressure on the side of that. And so as we bag, be able to see that chest rise and fall. The preferred method would be to have 2 providers and then to create that good seal, doing the jaw thrust, pulling the jaw up into the mask. So now we'll go into a little bit of the airway and breathing. So our very first steps with our airway, we're going to start out by checking for responsiveness, trying to get them to look and then trying to get them to open their eyes and pay attention to us. If the patient is unresponsive and 911 has not already been activated, make sure we're activating 911, placing our patients on their back, do a quick scan, looking for signs of breathing and making sure that they have a patent airway. If pulses are present and we have corrected the blocked airway, then we can start looking for any other things that may be blocking the airway, including secretions or solid objects. If there's anything in there and we can, then we're going to clear that out of their airway by either using suction, or if it's something that we can readily see, finger sweep and get that out of their airway. We then need to maintain that open airway. So we need to either physically stay in that position and manually open their airway, or we can move on to using one of our airway adjuncts and freeing up. Once we made sure their airway is open and is going to stay open, then we check for the presence of breathing, determine if they are breathing adequately, and if not, either our mask to mouth to mask devices. So all of that we've talked about up to this point has been for adults. If we're giving rescue breaths for children, there's just a few small things more and have more narrow airways. So we don't need to use as much force to open their airway when we're doing that head tilt. We can also tilt their head back far enough that we will occlude the airway the opposite direction. And so it's just like a little straw, and too much, it'll kink off as well. The other difference with our kids is kids intrinsically or naturally breathe faster and more than adults do. And so we're going to go from giving a breath every 5 to 6 seconds. And with our kids, we're going to give one breath every 2 to 3 seconds. So looking at doing our rescue breaths on our infants, like I said, it's really important that we are extremely with our infants as we're trying to open that airway so that we don't kink it off by opening it too far and cranking back as we do that head. It'll actually occlude the airway. So we're looking for a nice neutral position. With our little kids, often we find that patting underneath their shoulders is a better way to create that natural, neutral, inline position. And so if you have a towel or something that you can fold and place under their shoulders, it will help align that airway. And that's mainly because their heads are proportionally so much bigger than the rest of their body that as they lay down with their heads on the ground, it will cause their neck to move forward and occlude their airway that direction. So we're looking for a nice neutral inline position. And then it's going to be the exact same steps that we had for breathing with our adult patients. We can even do the mask device with these, where we use our barrier and we place it on there. With them, once again, we can really overinflate their lungs if we give them too much. So we're just trying to give them just enough that I don't know if you can see chest rides on there. If we have our mat or our bag valve mask, then we can do the same thing with them, making sure that we maintain that open airway. It's a little bit easier to maintain a seal all the way around if you're can you see the chest rise? So that's all we're looking for, is just a little squeeze so that we see. It's easy, actually. So the main causes of airway obstructions, talked about the main cause already, and that is going to be the tongue blocking the airway. That is easily fixed by doing either our head tilt chin. Our next most common is going to be food, hard candies, things like that. It's also really common for children to put small objects into their mouths and inhale, such as or balloons or coins. And then we also see a lot of vomit. Here's a crosscut diagram just kind of showing some different types of airway obstructions that we could see. The first we've already seen, our tongue causing an airway obstruction. We can also have injury to the neck, which may cause an obstruction. We can have obstructions from soft tissue swelling, creating pressure under the jaw and in the neck. And then assessing for our airway obstructions, we can ask the patient, just like when we were checking to see if they were responsive, start by the first question to ask is, are you choking? If the patient cannot reply at all, then the airway is completely blocked. If they can reply, if they can cough, anything like that, then it's a partially blocked airway. We also, one way that we can tell if an airway is obstructed, it's kind of the universal signal. Everybody kind of puts their hands up around. So we can have either a completely blocked airway where they're not able to talk to us, there's no air moving in or out. We can have a moderately blocked airway where you may be able to hear a little bit of air movement, kind of a whistling sound, or they may be able to speak a little bit. Or you could have a mild airway obstruction. These mild airway obstructions, we can encourage our patients to cough, and often if they're able to forcefully cough, they will be able to expel that object. If we do have a severe airway obstruction, meaning the patient is in or out at all, they're not able to speak, we're going to end up with this poor gas exchange because there's no longer oxygen entering the lungs and circulating to the body. And from all of this, we will then consciousness in anywhere from 3 to 4 minutes. If the patient is conscious and able to doing the abdominal thrusts, if the patient is unreal, what abdominal thrusts would look like. So come on in, Logan. So abdominal thrusts, I'm gonna have you actually stand here for a minute. So what we're gonna do, and he's actually taller than me, so it makes it a little more difficult. Hopefully most of you guys are not as height challenged as I am, but we're going to go and wrap our arms around them. We're looking for their navel or the belly button. We're going to create a fist right there at the belly button. Our other hand will wrap around, covering our fist, and then it is an upward movement. So we push in and up on these patients, and you'll do that until the obstruction is cleared or they become unresponsive. If they become unresponsive, there is an airway obstruction in a child. The only difference is we're not be doing the abdominal thrusts with them. If have an audible cry, that is the one way that we will be able to tell that they do not have a complete responsive. Then we're going to do the CPR. But to open the airway or to clear the airway in our infants, we will actually do back thrusts. And so we're going to take our child. We want to make sure that we are protecting their head. So we hold it, we will place them on our arm, and then we do back blows. And so you're just looking for the middle of their back using 5 back blows. You can flip them over and see if the airway has been cleared. If at that point they have become unresponsive, then you
usage.
So hopefully we will have some to us in our response vehicles or different equipment that we have. Our oxygen is just in a compressed tank. Normally there's about 2,000 PSI stored in them. Most EMS systems are either using a D or the D cylinders are a little bit smaller. Depending on the flow rate that you're using for your oxygen, each of those cylinders about 20 minutes. If you're using higher flows, if you're using a lower flow, similar to, is going to have a pressure regulator on them. As you're checking your equipment, you want to make sure that that is seated correctly. Most of these flow meters will be able to regulate the oxygen flow from anywhere from 2 to 15 liters per minute. They do have some flow meters out there that will do even quarter and liter per minute, which we will use for our infants. There is a gasket inside that flow meter to make sure that it's sealed, and you want to make sure that that has a tight seal. Sometimes those gaskets can get tightened too tight to the point where they no longer create. We can then our nasal cannulas can do either low to medium concentrations of oxygen. Our face masks go over the patient's entire face, their nose, and their mouth concentrations of oxygen. Our nasal cannulas will increase the amount of oxygen delivered to our patients. Normally, when we're breathing in and out just our normal air, it's 21% oxygen. So our nasal cannula will change that from the 21% oxygen that we normally breathe in to anywhere from 22 to 44% through that nasal cannula. And then our masks can increase that. There are some safety considerations when we, especially our compressed oxygen in these tanks. Oxygen supports combustion, so if there is a small spark or a flame, it can spread that quickly. So we want to make sure that if our patients are smoking or anybody around is smoking, that we have them stop. We also talk here about the oily substances, which would be our petroleum-based. Once again, making sure that we're not using any of those in our airway. And then also just know that that bottle is pressurized. And so we want to make sure that our oxygen cylinders are kept in some type of sturdy case so that they don't get knocked around. When you first get your oxygen, you're going to want to make sure that you put your flow meter on. There are 2 pins that you want to line up with the flow meter, making sure that it's on in the right direction. Tighten the screw end, and then you're going to turn the cylinder valve counterclockwise to open it, making sure. Stop it. Once you've opened your tank and you have noted that there are no leaks coming from that gasket, you want to check the pressure on the regulator to make sure that you have enough oxygen in the bottle. And then you will adjust that flow meter to the minute of flow that you want to give to your patient. Once the oxygen flow begins, then you can place it on the patient's face. We try not to place it on their face and then turn the oxygen on. Sometimes you can get a little overexcited and turn it too far, and we just don't want to. So as we talked about, our nasal cannulas, these are going to be low to moderate flow. And so we're looking at 1 to 6 per minute on these as we're adjusting that flow meter. And as stated earlier, this is going to increase that oxygen concentration. Reservoir, or that mask, these need to have a flow of at least in order for that reservoir bag to stay inflated. These can deliver concentrations, says up to 90%, depending on how it is blocked off. And their masks have long been recommended as the oxygen delivery device of choice for all of our patients that have shortness of breath, severe chest pain, carbon monoxide poisoning, any of these signs of shock or different things that may happen. I would just say I feel like in EMS we do a poor job at training to the end goal from the beginning. And so here in an EMR course, we are going to encourage you, and it's going to be part of your test, high flow non-rebreather oxygen on all of these patients. However, there have been a lot of studies that show that high flow oxygen can be harmful in some of these patients. And so what we will see is as our advanced level providers are showing up, they will then take off that oxygen and change it from a non-rebreather to a nasal cannula or take it off completely. And I just want to let you know up front and from the beginning, this is kind of a fin EMS where it's still talked about to put people on high flow, but we're moving away from that. And I don't want you to feel like as other providers are oxygen off of your patient, that they are then doing harm. We encourage you to put oxygen on, and high flow oxygen for short periods of time may not be harmful, but we definitely want to be making sure that we're doing the best thing for our patients. So don't be alarmed. Don't be upset if our advanced level providers show up and take that oxygen off. As a paramedic responding, I have had first responders, our EMRs, who will actually get upset and have called and complained that we're taking the oxygen off of our patient. Any patient that we are going to be giving supplemental oxygen to, hopefully we are checking a pulse oximetry reading for these patients, giving them oxygen, or definitely while we are giving them oxygen. Our pulse oximeters are used to look at the saturation of oxygen on the red blood cells. There is a sensing probe and a monitor. Sometimes these will come separately. A lot of our pulse oximeters that we're going to use in the field nowadays are these smaller devices where the sensor and the monitor are all in one, instead of what you see in the slides where it is the sensing probe. Have infrared light. Our healthy patients, we're looking for oxygen saturation 94 and up to 100%, depending on where you live. So this is a great textbook answer to say 94 to 100, but we can also see in some of our patients that live at higher elevations that 92 or even lower, and that is normal for them. The pulse oximeter doesn't necessarily tell us what is wrong with the patient, but it can help us recognize that the patient is having a problem and determine. There are some limitations our pulse when using our pulse oximeters. They may not give accurate readings if our patients have nail polish on, or if their fingers are really dirty, if it's cold outside, which will cause a reduced amount of blood flow to our if they've lost a lot of blood, you may not have good readings. And then if they are experiencing monoxide poisoning, you'll get a false high reading, as the pulse oximeter is just looking at those red blood cells as it goes by, and seeing if they are bound with something. It is unable to monoxide, or if it's oxygen that is bound to those red blood cells. So as great as a pulse oximeter is, it's just a machine. Considerations. There are a few special patient populations that we need to pay attention to when we're performing rescue breaths. One of those would be if they have a stoma, which a stoma is a permanent opening in their trachea, caused either by damage to their upper airway, normally smoking or trauma, where they now have a surgically implanted hole and opening in their trachea and in their neck. So you want to make sure that stoma, keeping the patient's neck straight. You can examine it to make sure that it's clean and doesn't have any mucus in it. If it does, you'll want to suction prior to doing any breath. And then if there is a breathing, few breaths. Just like mouth to mouth, if you're performing rescue breath, if you're doing that direct breath into the stoma and you don't see chest rise, then you're going to need to seal the mouth and the nostril using one hand and then breathe into the stoma once again. You are able to use your bag devices or pocket devices when ventilating into a stoma. It may be beneficial to have an infant-sized mask so that you can create a better seal directly over that stoma in their neck versus trying to use an adult mask where as you stick that over their neck, you're going to have a lot of leak around that. We can also see gastric distension when we're using any of these breathing devices, whether it be mouth to mask or our bag valve masks. And gastric distension just occurs when we're forcing air into the stomach instead of into the lungs. Basically, this is increasing the chance that the patient is going to vomit. To make sure that we're not forcing too much air into their stomach, we want to make sure that we're doing our breaths slow and that we're giving just enough to create that chest rise. It's also important that we make sure that their airway is fully open as we're doing that, looking for the chest rise, because otherwise that air is going to go directly into the stomach. If you have patients that have dental appliances, dentures, anything like that, uh, if they're in and firm, then we don't want to remove them, as it will actually help us create a better seal with our mask. But any loose dentures can cause problems. So if they're loose and as you're doing your airway assessment, then you notice that they're causing a problem, you want to take them out. That's one of those things you can take out with a finger sweep. You stick your finger in, you'll feel the back of the dentures and you... So airway management, if the patient is still in the vehicle, can look a little bit different. We may also need to use the jaw thrust maneuver with the patient either sitting or semi-reclined in the seat still. You'll be able to approach from the side, either leaning through a window or across from the other seat on the other side. If you are able to get into the back seat of the vehicle, then you'd be able to protect their airway and do airway maneuvers from that position as well. If you are able to either get behind them or lean in from a side with these patients who are sitting or in these semi-reclined positions, you'll be able to grasp their head with both hands. You'll put one hand on their chin, the other on the back of their head. You'll be able to maintain a slight upward pressure, supporting the head and cervical spine of these patients as you move them into a position where you can maintain their airway. So this would be if they're seated and their neck is forward, as you can see in the picture here. You'll use your two hands supporting their head and neck, tilting their head up and opening that airway. This is a great technique that has a couple of different advantages for us. If we're unable to get into the vehicle, it's easy for us to be able to reach in and open their airway this way. It allows us to monitor carotid pulses and their breathing just from using our fingers. It also stabilizes their cervical spine, making sure that if there is any possibility of spinal injury, that is secure. And it provides an open and patent airway so that they can continue to have adequate respirations. So we'll move into our summary for this chapter. The main purpose of the respiratory system is to provide oxygen to the body and remove the carbon dioxide from the red blood cells as it passes through the lungs. When a patient experiences a possible respiratory arrest, we want to check for responsiveness. We want to open a blocked airway using either the head tilt chin lift or the jaw thrust maneuvers that we learned. We want to check for anything in the airway, whether that be vomit or blood, any solid items, food, candy, toys that we may see, looking for any dentures that are loose and causing an obstruction in the airway. Once we have corrected that airway, we can also use finger sweeps or suction to clear those things out of the airway if needed. Once we have opened that airway, it's important that we maintain the airway, whether that be using a manual hold, or if we're going to place them in the recovery position, or use one of our many airway adjuncts that we talked about. If the airway is completely obstructed, then we need to clear that airway. We can do that by performing the abdominal thrusts, also known as the Heimlich maneuver, by wrapping our arms around them. Remember, we're creating a fist, placing that fist in the belly button, placing our other hand over top, and we're going in and up. Some of these patients are going to require supplemental oxygen if they're showing signs and symptoms of shock. We will use our pulse oximetry to determine the level of oxygen saturations that they have and target our oxygen delivery for those patients, making sure that we are giving them enough oxygen that it reads on our pulse oximeter. So if we're giving supplemental oxygen, we don't want it to read 100. So we will regulate the amount of oxygen that we're giving so that it's anywhere between that 94 and 99%. We'll move into our review questions for this chapter now. Question number 1. After opening the airway of a patient who has a pulse but is unconscious, you should perform a blind finger sweep, immediately attempt to insert an oral airway, check for secretions, foreign bodies, or dentures, or perform CPR. The answer for this one is going to be C. We want to check for secretions, foreign bodies, or dentures. Question 2, you should place a patient in recovery position to prevent patient from going into respiratory arrest, allow secretions to drain out of the mouth, protect the patient's spine from injury, or facilitate administration of supplemental oxygen. And the answer for this one is going to be B. They go into the recovery position to allow secretions to drain from the mouth. And the last question. Pulse oximetry is used to assess amount of oxygen saturations in red blood cells, provide supplemental oxygen to a patient, assess how much oxygen the patient requires, or eliminate carbon dioxide from the bloodstream. And the answer for this one is going to be A. Pulse oximetry is used to assess the amount of oxygen saturations in the red blood cells. It can also be used to help us target our oxygen delivery, but specifically oxygen or pulse oximetry is used for the assessment of the oxygen saturation. Awesome, guys. That is the end of this chapter. A little more fun, getting a little more hands-on with some of our equipment. A lot to learn in this chapter. You guys are doing great. I'll see you in the next chapter.